Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Risk of Adverse Health and Social Outcomes Up to 50 Years After Wilms Tumor, the British Childhood Cancer Survivor Study, by Wang et al. My name is Cindy Schwartz, and I am the Curtis Professor of Pediatric Cancer and the Division Head and Chair ad interim of Pediatrics at MD Anderson Cancer Center in Houston, Texas, USA. My oncologic specialty is pediatric oncology and cancer survivorship. Wilms tumor was one of the first pediatric malignancies to be effectively treated. Although nephrectomy cured a minority of children with localized disease, survival rates increased to 47% with the addition of radiation therapy in the 1940s. With the introduction of actinomycin in the late 1950s and the subsequent use of multi-agent chemotherapy, survival rates soared to more than 90% by the 1990s. Long-term, radiation-induced musculoskeletal toxicities emerged as young survivors grew to adulthood, leading the National Wilms Tumor Study Group to focus not only on enhancing efficacy of treatment, but also on the development of treatment paradigms that could eliminate or reduce radiation to these young children. Similar efforts in Europe resulted in changing patterns of care over the years, but the long-term survival of children with Wilms tumor treated in the mid-20th century provides a first glimpse into the very long-term impact of cancer therapy. In the manuscript that accompanies this podcast, the authors evaluated 1,441 survivors of pediatric Wilms tumor included in the British Childhood Cancer Survivor Study, a population-based cohort of 5-year survivors of pediatric cancer treated in the United Kingdom between 1940 and 1991. During this period, 70.5% of survivors who were alive and over age 16 years responded to questionnaires addressing health and social outcomes and were evaluated in comparison to normative data from the general population using the Oxford Health Life Survey, the General Household Survey, or the National Marriage Registry. During this period, 70.5% of survivors who were alive and over age 16 years responded to questionnaires addressing health and social outcomes and were evaluated in comparison to normative data from the general population using the Oxford Health Life Survey, the General Household Survey, or the National Marriage Registry. Wilms tumor patients scored significantly lower than the general population in physical functioning and perception of health, despite being less likely to smoke or to consume harmful amounts of alcohol. Utilization of health services such as hospital outpatient visits and inpatient stays confirmed the adverse perception of health. Deaths and secondary neoplasms were ascertained through linkage with the National Population-Based Death and Cancer Registration Systems and were subsequently validated. By 2010, there were 38,803 person-years of post-5-year survival, with a median follow-up of 26 years. 10% had died, resulting in a standardized mortality ratio of 5.4 and 30.7 excess deaths per 10,000 patient years. The standardized mortality ratio was 10.1 for cardiac causes and 7.3 for secondary neoplasm. When analyzed by time from diagnosis, the absolute excess risk increased remarkably beyond 30 years from diagnosis, from 14 per 10,000 person years from years 5 to 29 to 108.4 after 30 years. Beyond 30 years, secondary malignancy and cardiac causes account for 50% and 25% of excess deaths. By 50 years from diagnosis of this tumor of early childhood, cumulative mortality due to all causes other than recurrence was 22.7%. 16.6% was attributable to secondary neoplasms, of which 41% were digestive cancers and 7% were breast cancers, particularly beyond 30 years from diagnosis. The cumulative risk was 3.7% by 30 years, increasing to 16.4% by 50 years. Turmulin et al. Similarly reported a cumulative incidence of secondary malignancy of 3% in Wilms survivors in the Children's Cancer Survivor Study, treated from 1970 to 1986. Longer-term outcomes of the CCSS cohort are unknown. All patients with digestive or breast cancer were exposed to radiation. Data regarding exposure to chemotherapy and radiation is missing in more than one-third of patients in this report, but other studies describe prevalent therapies. Prior to 1970, data from UK death certificates show that nephrectomy, radiation, and chemotherapy were given to 90%, 80%, and 35% respectively of those with Wilms. National treatment trials exploring chemotherapy for Wilms tumor in the UK began in 1970. More than half of patients continue to receive 20 to 30 gray. There is remarkably little data elsewhere about very long-term complications of cancer therapy. 67% of the British cohort were more than 30 years of age, and 21.9% were more than 40 years from diagnosis. 67% of the British cohort were more than 30 years, and 21.9% were more than 40 years from diagnosis. With a mean age of 3.3 years at diagnosis, most were young adults at the time of this report. 88% who completed questionnaires were under age 40. Despite the excess of digestive and breast cancers beyond 30 years from diagnosis, most of these individuals would not be considered for either colonoscopy or mammography by standard algorithms. The data suggests consideration of such individuals as high risk to encourage early detection through screening. Cardiac monitoring and preventive strategies should also be considered in this young cohort, given the high and increasing risk for cardiac morbidity. While this is a limited cohort of children treated 30 to 50 years ago, survivors from that era need ongoing and appropriate monitoring. In addition, cohorts of young Wilms tumor survivors and survivors of other malignancies continue to receive these and similar therapies and will be at lifelong risk. Also to be noted is that analyses were based on years from diagnosis rather than age at the secondary neoplasm or cardiac event. We should therefore be cautious in assuming that heart disease or a digestive cancer will not emerge until 30 to 40 years post-radiation. Risk is likely related to the exposure, the time since the exposure, and the organ risk at a given age. It is possible that the risk of digestive cancers after abdominal radiation is increased in any patient approaching the age of 30, regardless of time of diagnosis. An adolescent with cancer might then be at risk earlier, within 10 to 20 years, rather than at age 50. Further analysis is needed to determine whether guidelines for screening should focus on current age or time from diagnosis. The life expectancy of a 40-year-old is decades long. If risks continue to increase, the potential impact on long-term health and survival is significant. Studies such as this, with data linked into the national registries, provide an outstanding opportunity for ongoing acquisition of knowledge. This critical insight toward understanding of the long-term effects of cancer therapy should influence recommendations for medical monitoring over a lifetime. Cure is not measured by the eradication of illness, but by the maintenance of long-term health. As the survival rates of cancers continue to rise, we need to listen when the patient questionnaires relay health concerns and evaluate outcomes with the intent to intervene when possible to promote wellness. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.